So I'm Sasha Perl from the University of Pennsylvania, and I've been asked to comment on the topic of MRD measurements in the management of patients with FLT3-ITD positive AML. The data I'm presenting here at the ASH 2023 meeting in San Diego comes from a study of the Quantum First study of quizartinib added to frontline intensive induction chemotherapy and consolidation therapy and maintenance therapy for patients fit for intensive therapy who had FLT3-ITD mutation. And on this study, we collected samples prospectively to look at whether MRD positivity, as measured by an assay that could detect FLT3-ITD mutation at exquisitely low levels, was predictive both of long-term survivals and whether quizartinib would lead to deeper levels of MRD, and whether, again, that would be predictive of the overall survival benefit that was seen on the study. So the assay that we used was what's called a PCR NGS assay. It uses PCR to amplify the region of the FLT3 gene in which the mutations occur, but those amplicons are then sequenced, and that allows you to get much greater sensitivity than a standard diagnostic PCR assay for FLT3 in the diagnosis of AML. Indeed, with this assay, we could quantify the FLT3-ITD burden down to 1 × 10⁻⁴, and we could detect FLT3-ITD mutations about 2 orders of magnitude below that. So 2 × 10⁻⁶ was the lowest level detected with this assay. What did that show us? At defined time points that were pre-specified, we looked after patients entered remission after 1 or 2 cycles of chemotherapy, after 2 cycles of chemotherapy to match standard time points for measuring MRD, and then after the consolidation phase of the therapy, we saw consistently that patients who had any level of detection of FLT3-ITD with this ultrasensitive assay had worse survival. And that also the FLT3-ITD levels associated with quizartinib therapy were lower than in the placebo arm, suggesting that this might have been perhaps in part one of the reasons why we saw better survival on the quizartinib arm. Now, this study is not alone in terms of looking at the level of FLT3-ITD burden, and this is coming into routine use in clinical practice. A recently released data set looking at this question in samples collected just prior to bone marrow transplantation for FLT3-ITD positive patients, a study called the MORHO study that was presented at the EHA meeting this year by Mark Levis, showed that patients who had residual FLT3-ITD sequence, again, at any level down to 10⁻⁶, had worse survival, and also that their survival was improved in terms of their relapse protection and their relapse-free survival if they received post-transplant maintenance on that study with a drug called quizartinib, a different FLT3 inhibitor. So again, from multiple studies now, we're seeing that measurement of FLT3-ITD MRD is emerging as an important way to risk stratify patients and also potentially to allocate therapy. And I think this is going to increasingly be integrated into routine treatment of patients with FLT3-ITD positive AML.